osteoporosis today. Bear with me in the beginning of the talk, because I tend to get a little bit scientific and talk about the anatomical and physiological elements of different organs. And I think when we know how our body works, we're more likely to follow through with why we make certain recommendations. So the first bit of the presentation is going to be a little technical, and then we're going to talk about lifestyle and other treatment considerations for prevention and treatment. I just mix them together, of osteoporosis. So that's Dr. Lena, Kian. I'm a naturopathic doctor and a graduate of Astor University. I have a practice in Sunnyvale, right next door to the library, so we're neighbors. The primary areas that a naturopathic doctor focuses on is primary care. So we focus a lot on chronic ailments, especially like diabetes, heart disease, digestive disorders, hormonal imbalances. There are a lot of YouTube talks as well that I've done from previous libraries you guys can refer to. And we focus a lot on natural therapies like nutrition, homeopathy, counseling, a lot of botanical medicine, and especially looking at finding the cause of health problems. So what we're going to talk about today is a preview of naturopathic medicine, what NUs do, and then we'll talk about anatomy and physiology, and then risk factors for osteoporosis and osteopenia, and then we'll talk about treatment in terms of nutrition, lifestyle practices, do's and don'ts, and then some other consideration like exercise. Have you guys heard of naturopathic doctors? Raise of hands. Okay, good, like a good 50% of a room. That's great. So the doctors that practice naturopathic medicine are called naturopathic doctors, NDs in short. So here's the short form. There are a lot of terms that are confusing, like holistic medicine, complementary, alternative. What makes NDs unique is that we go to medical school. So we have a 4-year postgraduate medical training. We're able to diagnose, order labs, treat. It's very comprehensive, like your medical doctor or your osteopathic doctor. So you can see NDs are trained in the same level as MDs and DOs. They attend a 4-year postgraduate medical school. And in addition to the standard curriculum, we get a lot on preventative therapies like homeopathy, nutrition, botanical medicine. So it is approved by the Bureau of Naturopathic Medicine. It's a licensed profession in California. As I mentioned, we focus a lot on diagnosis and treatment of health conditions. So these are all the areas that we focus a lot on. My goal when I do these talks is to make them kind of something that you guys can walk home with and apply yourself, because we believe that we all agree our body has a great ability to heal itself, right? So what we want to do is get in the way of kind of things that are in the way of the body, like obstacles to cure. And everything okay?
Yeah, I just went into
Okay.
the trip.
Oh, thank you. Yeah, in a lot of the talks that I give, I want you guys to have the tools to apply as soon as you get home. A lot of nutrition, lifestyle practices. And if anything, I want people to be their own best doctor and really tune inside and find out what their body's trying to tell them. So a lot of focus on nutritional counseling, using vitamin and mineral therapy. And part of the reason I wanted to focus on osteoporosis is we tend to think of buzzwords like calcium, vitamin D, and then the conversation ends sometimes at that. So I kind of want to expand our kind of viewpoint of what that really means. And then there's other treatments I mentioned, homeopathy, counseling, a lot of lifestyle, which we'll talk about today. And finally, just to wrap this up, these are the principles that we follow in every single case. And you can see the very first one is using the healing power of nature. Your body has a great ability to heal itself, and we want to use that power to be able to stimulate the healing process. Identifying and treating the cause. And first, do no harm. I think this is probably the one we'll talk a lot about today. In terms of risk assessment with osteoporosis, the most important thing with osteoporosis is to reduce the risk of fractures. So first, do no harm is about that. It's not just about, okay, your bones need help. Well, it's not just about the bones. The bones are like the structure for which you're able to move. So if someone, basically falls, fracture prevention and fall prevention is something we want to focus on with someone who's at risk. So first, do no harm, treating the whole person, mind, body, and spirit all together in one. Doctors, teachers, so the word doctor in Latin, which is docere, means to teach. So we really love to get out there and educate. And then prevention. I think this is another topic with osteoporosis, that prevention is a big one. So let's get to the essence of the talk, in terms of bone basics, if you can look at the typical bone, you can see that bone provides the structure and allows for movement. So it's really the framework in which our muscles and ligaments are able to do what they do when we're able to move our body. But in addition to that, it actually supports organs, right? All the internal organs of the body are functioning within a certain structure. And then something we don't even think about, your bone produces red blood cells and white blood cells. So, and it stores minerals. So the conclusion here is that bone is a living tissue. Have you guys thought about that? Like your bones are a living tissue. We just think of it as like a wall, right? It's like a structure, but it's a living tissue. And the reason I want to emphasize that is when it comes to what osteoporosis means. So just remember this, this big sentence. Part of the reason that it's a living tissue is that it's constantly being repaired and remodeled. So it's not just something that's rigid and there the rest of your life. There's actually a constant remodeling process that happens for your bone to be always in a state of health. So and normal bone remodeling is a balance between bone breakdown and bone formation. And bone loss is basically that this imbalance, it leads to more breakdown than more formation. So when we talk about osteoporosis, we want to stimulate more formation and we want to reduce breakdown. That's really that balance we want to focus on. So if you look at that balance, there are different cells of your bone that promote that. There's osteoclasts and osteoblasts, and I don't want to get too technical here, but think of it as like a road pavement. So if you look at, well, think of like when we're repaving the road, right? We're not going to just put more asphalt on top of the old. We're going to break down the old, make like a clear structure, and then add the new, right? Otherwise, it'll just be pile after pile. So the way your body makes new bone is it breaks down the old, clears the space for new bone to be formed, okay? That's why it's not bad for this cell, what we call osteoclast, which means that it erodes the bone. It's not bad. We think, oh, bone erosion, bad. It's doing that in order for new cells to come and build the new, okay? So when it comes to osteoporosis, we don't want too much of this because then the bone density gets low. But a normal amount of bone breakdown is good in order for new bone to replace it. Does that make sense? So that's kind of what this is saying, is here's that osteoclast is the one that's breaking down the bone. You can see like a little cavity here. And then the new proliferation, the new bone comes and it causes new bone to be formed, and then it starts to basically get built up. Skip that here. So what happens in terms of development? We know that until the age of 20, we can actually increase our bone mineral density. This is why we focus so much on growth, you know, kids growing and building, you know, calcium for our teenagers and children. And then after the age of 20, our bone density stays the same until about 35 to 40. And then the rate, depending on the gender and where we are in our stage of age, it goes down. So you can see both men and women begin losing bone at a rate of about 0.5 to 1% per year. But women start to lose more within the first year after menopause. So now we know there's a hormonal relationship between bone loss and menopause. So about the first year it loses about 2 to 5% per year. And then in men it is kind of slow until about age 65 it starts to become more rapid. So these are the age groups that we start to get a little bit more focused on in terms of preventing osteoporosis. So what's the definition of bone loss? We know that it's basically accelerated, and usually at menopause it's more accelerated because of estrogen deficiency. So again, back to menopause is basically the reduction of hormones, especially estrogen and progesterone, but we know that estrogen plays a big role in terms of bone mineral density, and that's why menopause is the place where bone absorption starts to go down. And then it starts to go down 2 to 5% per year for the first 4 to 5 years. And then this kind of continues slowly from age 55 to 65, and then starts to get more significant age 65 to beyond. But I don't want age just to be the only factor, because there are other factors we're going to talk about. And you could see factors like nutritional status makes a difference. Certain medications can affect the way you absorb bone minerals. and then your activity levels. So we're going to talk about that coming up. Before I do, this term sometimes seems mysterious that we talk about breaking it down. So osteo means bone, and then porosis, think of like pores. So if you look at like a normal bone here, see how rich it is? It's like very mineral dense. And then when you got osteoporosis, you got more holes. It's like porous, right? That's what the word porosis means. There's more pores. There's less density in the bone. So that's what we're trying to avoid. And that's what the definition of osteoporosis. It's a metabolic bone disease, meaning that you're losing some mineral density. So reduced bone mineral density or reduction in the structure of the bone. That's basically the definition of osteoporosis. And then when that happens, it increases the bone fragility. The greatest areas where the bone loss is most susceptible is in the spine, the hips, and the ribs. And you could imagine if we're trying to do fall prevention, those are the areas we want to support. So just as a preview, we want to focus on fall prevention. That's really the focus of this talk. Most of the cases that happen is in postmenopausal women, as I mentioned, due to the changes in hormones. And 90% of the hip and spine fractures happen in Caucasian women between the age of 65 and 84. So now we know the hip and the spine are most susceptible to fractures. So you can see the conclusion is the primary clinical goal of osteoporosis is management through reducing risk factor. So going back to definition of what osteoporosis is, first of all, by definition, there's really no symptom. That's why it's called the silent thief. The only time it starts to show up is people complain of low back pain or maybe they have reduced height, but there's really no like clear symptom that, okay, this is classic osteoporosis. So it sometimes requires a certain amount of screening, which I'll talk about how you can screen for osteoporosis. By definition, the World Health Organization defines osteoporosis as a bone density that's 2.5 deviations below the standard deviation of compared to that of young females. So that's according to DEXA, which is a bone density scan. And what that looks like is kind of like an X-ray machine that you lie, and it measures your hip and femur bone density. So hip and spine, I'm sorry. The two sites that are measured, and then it's just a very low X-ray that goes through. So it's not a scary test to do, but definitely gives you an idea of your bone mineral status. Have you guys, anyone? I mean, maybe it's a little private, but some of you just nod your head. Are you familiar with the bone mineral density? Some of you may have had that. Yeah, I see several heads. So you can see that the way they do it is through a t-test and a z-score. Anything between, actually this one's better. So anything less than 0.1 is considered normal. Osteopenia, which is borderline osteoporosis, is between -1 and 2.5. And then anything less than -2.5 is defined as osteoporosis. So remember that philosophy we talked about, first do no harm? This is the place where this comes in. Because you can see if we have osteoporosis and there's only one vertebral fracture, the risk of another fracture happening increases by 5 to 7 times. So having one fracture increases your risk of another fracture 5 to 7 times. So it's almost like a trickle-down effect, and that's what we want to prevent, is having that first fall, but really being extra protective if should that happen. A lot of times, it results in loss of motility, a lot of pain. Your quality of life, a lot of times it really impacts that person's future. So really what we want to focus on is preventing osteoporosis. So this is, again, somewhat of an alarming fact if you look at it. So the average age of hip fractures is 82. You can see 25% mortality within the first year. And then 25% require long-term care after the first fracture, and then 50% have long-term loss of mobility. So again, prevention, because it's the quality of life that gets affected as a result. And then a lot of times the vertebral fractures happen a little bit sooner, somewhat in the mid-70s. And then there's a lot of pain that may be associated with that, obviously loss of height. It can even restrict your range of motion. You can imagine if your vertebra gets compacted, it could reduce your breathing, right? There's like less structure for which your lungs can expand. It can even affect your digestion. You can imagine someone who might have, you've seen kyphosis, people who are like more bent. It really compresses your digestive and your lung capacity. So we definitely want to try to prevent that as much as we can. Okay, so what are the causes? It always goes back to how can I prevent this? What is the cause? In this case, you can look at various things. Heredity makes a big difference. So body size, it's in your handouts actually. Anyone who weighs less than 127 pounds is at a risk for osteoporosis, just because, believe it or not, weight actually provides some sort of resistance on your bones and muscles, right? So those who are muscular are actually putting some sort of a strength on their bones. So anyone less than 127 pounds may need to get screened, and then genetics. We know that Caucasians are at a greater risk. Poor nutrition during growing years, because as we said, up until the age of 20, you're building bone. So if you're missing that critical time, you might have some catching up to do later on. Lack of physical activity, both nutrition and physical activity during your developmental years are going to increase your likelihood of building bone. So we really want to focus on that. Later, delayed puberty has to do with hormones. Again, hormones do play a role in bone mineral density. And then increased bone loss, maybe again, estrogen and androgen deficiency play a role. So you know how we said in men over the age of 60 to 75, their rate of osteoporosis increases? That correlates with their androgen or their testosterone levels increasing. So in women, it has to do with more menopause and estrogen, and then in men, it has to do with testosterone. And then secondarily, we're going to look at vitamin D deficiency, and then certain drugs, which I'll talk about, playing a role in osteoporosis. So primary cause of osteoporosis is lack of estrogen in women, lack of testosterone in men. And then the secondary is other medical conditions that are linked to it. So we can look at hyperthyroidism, so you always want to get screened for thyroid conditions. Digestive, so people who have either celiac, irritable bowel disorders, they're less likely to absorb minerals. That's why it plays a role with osteoporosis. Rheumatoid arthritis, this is something I always have to remind myself, anyone who has rheumatoid arthritis, I want to make sure their bones being extra protective because they correlate. Those who have RA are more likely to have osteoporosis. Chronic kidney disease, that has to do with vitamin D and calcium absorption. And then drugs that affect bone mineral density. I'm really going to talk a lot about this, so it might be coming up. It'll be coming up soon. So in terms of screening for someone, anyone with a history of fracture after the age of 40, you want to kind of be on the alert. Anyone with a parent who has hip fracture, anyone who's used steroids. So here's the first drug we're going to talk about. Steroids increases your risk of osteoporosis. So anyone who's been taking chronic steroids, I always want to know why. Are you taking it for some other reason? Is there a way we can decrease it? So this is especially the case for those who take steroids for rheumatoid arthritis or some kind of an autoimmune. We want, especially oral steroids, we want to make sure why. Can we do something else that's more natural? So yeah, we talked about that. Okay. And then also evaluating for chronic back pain. So if you guys are getting treatment for back pain and it's not getting alleviated, you might want to consider maybe it's bone density issue. After menopause, the area you want to kind of do a risk assessment is this person likelihood to have dizziness? Like if they're dizzy, they're more likely to fall. And if they have osteoporosis, they're more likely to have a fracture, right? So you want to double check that they don't get dizzy, balance problems. If they have weak muscles, we're going to talk about how to address all this. Decreasing coordination, difficulty standing or walking, arthritis, again, just balance and pain, impaired vision, and then and then side effects of certain medications. Some medications may make the blood pressure go too low and then they get dizzy. So just making sure that these risk factors are looked at, because anyone with 4 or more of these risk factors has an 80% greater risk of falling, and especially if they have osteoporosis, that's a bad combination. So when we talk about loss of height, especially if it's over 1.5 inches less than your normal adult height. That's a red flag. And especially if someone has like that kyphosis kind of look. And then, definitely I would recommend someone getting a DEXA scan if that's happening. Okay, this is according to the North American Medical Society. They have a position on when to do bone mineral testing. So anyone over the age of 65 should get screened at least once, and depending what their results in, they might just have a routine screening, or if they have osteoporosis, at least once a year, maybe once every 2 years, but a regular follow-up once treatment's implemented. Postmenopausal women who are taking certain medications or have medical causes. So if they're using steroids, if they have hyperparathyroidism or malabsorption like celiac I mentioned, or rheumatoid arthritis, you want to screen them regardless of whether they're 65. So if they're postmenopausal at 51 or 52 and have this condition, you want to screen them and do a DEXA. So that's where that age 50 comes in. And I think I covered that. Okay. So this pretty much says the same thing, but in addition, you want to look at these other factors. So low body weight, less than 127 pounds, and then a parent who has had a history of hip fracture. So there's a genetic history as well. Smoking, by the way, is an independent risk factor for osteoporosis. So a smoker is going to be factored in. I'm going to refer you guys to a website where you can check your own risk factors. So just kind of hold up on that until we talk about it. RA is rheumatoid arthritis. Another risk factor is alcohol intake. And the ENAM's position basically looks at what alcohol intake is. So anyone drinking more than 2 units a day. So 1 unit of beer is 12 ounces, wine is 4 ounces, and hard liquor is 1 ounce. So more than 2 of these a day is a risk factor for osteoporosis. So here's kind of ranking it. The strongest factor is age and body size. More moderate factors are family history, nutrition, physical activities. But you don't want to overlook hormones. You also don't want to overlook medications that may be getting in the way of mineral absorption. Okay, other risk factors. So as we mentioned, poor nutrition, vitamin and mineral status. We're going to talk about foods to eat next in terms of optimum bone density. Anorexia, so obviously that reduces the risk, the rate of nutrient intake. Smoking, you could see a 15 to 30% less bone mineral density. Huge how it can affect bone mineral density. Excess caffeine and alcohol should be in your handouts, but a lot of people freak out. They're like, what about my coffee? There's actually a few studies that I saw that said over 300 milligrams of caffeine a day becomes a problem. So if you're under that 300 milligrams, I think that's like maybe, I don't know, a grande or something, or whatever that biggest drink is at Starbucks. But if you're having like 1 or maybe 2 cups of coffee, that should be okay. Just don't go more than 300 milligrams of caffeine a day. We talked about alcohol use. Soft drinks, huge problem when it comes to osteoporosis. We'll talk about that actually in a little bit. High sodium intake. I put restaurants because if you guys are putting salt at home, especially if it's sea salt, don't worry about it. When you eat out, you get like infusions of sodium. I mean, like probably 10 times the amount you normally would at home. So it's more eating out that I worry about in terms of sodium intake. Lot of thought about adding fluorinated water. When we add that to our water, it actually leaches calcium out of bone, so it could affect even growth. So it's kind of on the fence, but I definitely do get concerned about our water quality. So trying to get a reverse osmosis filter where you're not getting chlorine or fluorine into your water. And then obviously a sedentary lifestyle. There's actually a really good book that I recommend. It's called Sitting Kills and Moving Heals. So maybe write that book down. It's actually, I think the library may have it. It talks a lot about how, well, here's the study. So this was written by a NASA researcher who looked at the effect of zero gravity. So astronauts who were under zero gravity. Keep in mind these astronauts do rigorous exercise training before they go up to space, right? So they're already in amazing physical shape. But in the process of going in, up at zero gravity, there's a lot of degeneration that happens in their body because there's no effect of gravity kind of at opposite force to their body. So she started to notice that these physiological changes that happen at zero gravity almost are similar to how we are when we're sitting all the time. It's not scary. It's almost like no gravity because we're sitting. So that's why she had the book called Sitting Kills, Moving Heals. And I actually had the privilege of hearing her talk at the Mountain View bookstore. And one thing that really struck with me was she said, if you think that you could do a half-hour workout and then sit on your butt the rest of the day, you're kind of fooling yourself. You want to do things every single day, and you want to get up. Don't sit constantly. Maybe every 30 minutes, get up. Like in my office, I have my printer at the other room, so it forces me to get up and get it. Drink lots of water so you go to the bathroom. Just do things every day where you're unconsciously forcing yourself, because when we're busy, we can sit hours and hours and not get that gravitational kind of challenge. Park further. People are obsessed with parking like right next to the store, and they're like fighting with each other trying to get the closest parking lot. So just the little things you do every day, like thinking about brushing your teeth. Just every single thing that you do moving your body awareness is a really huge factor in terms of getting yourself connected with what your body does for you every single day. So sedentary lifestyle is basically a huge risk factor for osteoporosis, but so many other health conditions like heart disease and diabetes. These are some medications to take a note of that do get in the way of bone mineral density. The one I want to spend a little bit of time on is antacids, or what we call proton pump inhibitors. A lot of people know this as Prevacid or Pepcid. You guys know that? The problem with these is they block acid formation. And again, it goes back to why is the body producing acid? The reason it does that is because it's breaking down food, especially protein. When your body breaks down food, it helps you to absorb minerals, right? I'm sorry, just for the sake of this being recorded, can you just, thank you very much. So just think about how many people who are using antacids every single day. And what happens is their stomach acid gets suppressed. And yes, they're using it because they're having heartburn, but when you suppress stomach acid, your body doesn't absorb the minerals, the vitamins, it doesn't break down protein, and it really gets in the way of optimum nutrient absorption. So again, it goes back to that phrase, find the cause. If someone's taking antacids just for the symptoms of heartburn, can we find out why the person's having heartburn to begin with? And then, if the cause is, we're trying to find the cause, whether it's a food allergy, whether it's stress, maybe it's a hernia, whatever the cause may be. In the meanwhile, maybe we could do some botanical remedies that can still protect the esophagus and not block acid absorption. So this is a big one. And I think this is a huge reason why osteoporosis is so prevalent. Because if it's just about drinking milk, I think we're drinking more milk now than we ever used to the previous decade. So I think there's something about antacids affecting it. And we're also drinking a ton of soda, which is another reason that I think we're having more osteoporosis. Another one to think of is the drugs like Actos and Avandia. They're actually used for diabetes. So diabetic medications do play a role in affecting bone mineral density. Also steroids like prednisone, you want to take a look at that. So any of these, you might want to ask, is there a natural alternative I could use to still control my blood sugar and not have the risks? I definitely don't encourage you guys to just stop the medication for the sake of side effects, but find out, is there a way of finding the cause or treating it through natural ways? And then also anticoagulants like heparin. This is the site that I promised I would mention. If you guys, this is in your handouts. It is 3/4 of the way down. It says website for assessing fracture risks. Very, very good website. You could go in there and type your demographics. I'll talk about the criteria they ask. And then you could find out your 10-year probability of having a fracture. So it's a really well done website. It was done by the World Health Organization, and it looked at a variety of populations. So from Europeans to Asians to Australians. And what it looks at is age, gender, weight, height. It does require you to put your bone mineral density, but you could still factor in that in if you haven't done it. So that's what the BMD is basically the DEXA score if you've done a DEXA scan. Prior risk of fracture, will ask you about that. It'll look at family history. It'll look at tobacco smoking, use of steroids, rheumatoid arthritis, other causes, and then alcohol intake. So if you look at this FRAX website, it almost is like listing your risk factors right there. So all the things we talked about, it's screening you for it to see what your probability of having a fracture is. Okay, so that topic is done. I just wanted to point out other areas to look at because I think a bone mineral density is really important to do if for screening people, but there's other tests to look at. So a lot of us have now known about vitamin D. More and more doctors are checking their patients for vitamin D, and a lot of people are showing low. It's not a surprise. If you show up low, don't be shocked. I'm always up, playing tennis and my levels are low. I don't, there's a lot of factors related to it, which I'll talk about. But you want to make sure, especially if you have osteoporosis, you want to keep your levels somewhere in the 50 to 60. So we'll talk about what supplements to take to keep that low. Has anyone heard of this term, homocysteine? Some of you who came to the heart disease talk or diabetes talk may have heard of it, and you're like, what does that have to do with osteoporosis? That's a heart risk factor. Well, guess what? It factors into bone. Homocysteine is an intermediate of a protein that your body basically metabolizes. So methionine is the protein, and then it basically has these intermediates, and then it breaks it down to cysteine. If the body's missing B12, B6, or folic acid, these vitamins, then it cannot complete the whole process, and it starts to dump out homocysteine. So you can ask your doctor for a blood test called homocysteine. If it ends up being over 10, there's an association with having possibly low levels of B12, B6, or folic acid. So it's kind of a sneaky way of checking vitamin status. A lot of people end up having like a genetic kind of a conversion problem to folic acid. So there's an active form of folic acid called methyl tetrahydrofolate, or 5-MTHF. And so some people may be saying, I'm taking a B complex, it has folic acid in it, it has B12 and B6, why is this still a problem? You might want to take the active form of folic acid, which is the 5-methyl tetrahydrofolate, 5-MTHF. So if you can see, if homocysteine levels are high, there's a positive association between high levels of homocysteine and near doubling the risk of osteoporosis fracture. And this is according to the New England Journal of Medicine. So it's an independent risk factor for osteoporosis. And you can see folate, or folic acid, B6 and B12, affect bone metabolism. This is, I think, why one of my favorite nutrition professors always said, what's the magic word? And we were like, leafy green vegetables. And it just blows my mind because leafy green vegetables are the highest nutrient-dense foods in all kinds of minerals and vitamins you can imagine. And when we talk about things like kale, broccoli, bok choy, Swiss chard, preventing heart disease, preventing osteoporosis, and we're like, how? And then we start to see, well, really rich in certain nutrients, and now we know some of the nutrients that play a role. So you can start to kind of link science and nutrition, and it's really fun to do that. The other tests you may not be as aware of are a test called NTX. This is it's actually a urine test. You could ask your doctor for. It is somewhat of a conventional test. This one is a more rare test, vitamin K assay. There are only certain specialty labs that do that. I think there's going to be a lot more talk about vitamin K in the future, just kind of like how vitamin D, like in the last 10 years, has become so popular. Vitamin K is next, my guess. And we'll talk about why. So first, let's talk about NTX. It stands for N-telopeptide. And basically, it's a collagen. It's like the framework in which your bones are made. So it's kind of like if you look at the way we make walls, there's like these frames, right? So it basically is like the collagen, the essence of which the bone can build on itself. So when this number goes down, it's an indication that your bone mineral density is going down. And the reason I like doing this test is that you can only do the bone mineral density, the x-ray, only once a year or maybe every other year. You can do this every 3 months or maybe even sooner. So I don't want someone to have to wait for a year to know whether their treatment's working, but they can get a baseline. So let's say they have their NTX number is lower than expected. And so we say, okay, let's start you on a good program. Let's get you eating better. Let's get you on a good calcium, magnesium, vitamin D, vitamin K, like a good comprehensive program. After 3 months, let's check your levels of the NTX. If that number's gone up, it's a good confirmation that we're on the right track. So that way I don't have to wait a year for anything else. So you can see the advantages. It's actually quite cost effective. It can be repeated frequently. Vitamin K is another area I'm really excited by. It's also a good one to monitor, just kind of like vitamin D. They go hand in hand. The risk of fractures increases with vitamin D deficiency. But guess what? Vitamin D also protects the heart. It also has anti-cancer effects. If you start to look at research in vitamin K, you'll be blown away of how many preventative conditions vitamin K can help with. Again, the richest source of vitamin K is leafy green vegetables. So there we go, more connections. So symptoms of vitamin K deficiency could be increased bleeding. So it could be bruising, nosebleeds, anemia, GI bleeding. But look at the ones related to osteoporosis. Increased risk of fractures, increased risk of osteoporosis or osteopenia, and then calcifications of heart, of soft tissue. So vitamin K in some way directs calcium to go into the bone. And just remember that, because soon I'm going to talk about calcium. Have you guys heard calcium getting bad talk in the public? Oh, it causes calcification of the arteries, and be careful. I'm going to break that myth a little bit, but there is some truth to it. So we'll talk about that. But vitamin K is essential in directing calcium from causing clotting or any kind of calcification of the arteries and directing it to the bone. It can also help with malabsorption issues, so deficiency, you might see a correlation. You can see heart disease, cancer, and then malabsorption. So there are 3 different forms of vitamin K. K1 is highest in, here's the fun word, leafy green vegetables, kale, broccoli, collard greens, and lettuce. K2 is more high in fermented foods, so you can look at cheese, meats, or dairy products. And then you could also supplement with vitamin K. Okay, now I'm going to talk about the most common pharmacologic treatment, which is the bisphosphates. I just want to raise your awareness on some of the potential risks associated with it and when to consider taking it, when to consider maybe getting off of it, and what conversations to have with your doctor. So I just want to get kind of our thinking tank on, not necessarily to say it's good or bad, but is it good for you? Are there other areas you could do in adjunction if you're already taking this? My concern sometimes with people who just take a medication is they think that's all they need to do. But don't ever forget your lifestyle. It's the same thing with diabetes. You can't just pop metformin or a diabetic medication and eat badly or not exercise. Your lifestyle goes so much further than just popping one pill. So, the same thing goes with treating osteoporosis. There's a lot of good that this medication does, and I'm going to illustrate that, but I just don't want you guys to just think that's all there is. So, the recommendations for pharmacologic treatment is all postmenopausal women who have osteoporosis, whether it's just previous history of a fracture or ones that's just been shown on a DEXA scan. So anyone with a score of -1 and higher, or with a positive 10-year, remember that FRAX score? So if they score positive as a risk factor, that also to consider taking it. The major medication is the bisphosphonates, and these medications you could see treat effectively. They reduce vertebral fracture risk by 40 to 70% after 3 years. But this is what's interesting. Look at the first year; it reduces the risk by 60 to 70%, and then the 3 years it's 40 to 70. So the first year it does most of the work. Okay. And then it continues to help you for, that 3 year, the third year mark. I just want to skip here. Persistent effect at least to 5 years for fracture and longer for implant. So the point with that is, because there are a lot of people who have side effects to these drugs, what they're finding is that even if you can take the medication for 3 to 5 years, you're gonna have benefits after stopping it, longer than those 3 to 5 years benefit. So if you have to stop it, know that it's still protecting you after stopping it at that point, because the most benefit happens within the first few years of taking it. Okay, so the reason for that is that the treatment stops that progressive breakdown, because osteoporosis is more breakdown than making bone, right? So this medication just interrupts that imbalance, and then once that balance gets reset, you don't necessarily need to take it in a long-term basis if you can't tolerate it on a long-term basis. So these are some examples if you're wondering what in the world are bisphosphonates. Fosamax, Boniva, Actin, or OB class. Those are examples of bisphosphonate medications. So the mechanism is that they inhibit the cells that break down bone, the osteoclasts. So basically there's more bone turnover or bone buildup. Short-term use, less than 5 years, may improve bone density. So there are positive studies with this medication. But the problem is that there are side effects. Some of them can be addressed more simply. There are a lot of people that get kind of more heartburn-like symptoms. That's why your doctor may say, take it first thing in the morning as you're standing upright and take it with food. That way, if you got some protective effects, if you take it and go to bed, it's gonna damage that lining. So that part we can kind of try to prevent, because you can see the last thing you want to do is cause esophageal cancer. This is the one that concerns me. I've yet to see a patient with it. I've had people tell me, they have family or friends who've had this. So I've never seen it myself, but it just worries me that you hear something like jaw death, and the word osteonecrosis is literally your jaw breaks down. So there are these side effects that are unusual. Another one is called frozen bone syndrome. Sometimes what it does is it stiffens the bone. So it's almost like, remember, bone is a living tissue, right? If it's too stiff, it might break down in areas that typically don't break. So that's what frozen bone syndrome is that you start to see these fractures where they normally shouldn't happen. So the strongest part of the femur might start to break, like right around here, and that's a side effect because it's odd for the body naturally to do that. If someone has these concerns, again, talking to their doctor about, well, if I've taken it, if I can tolerate it as long as I can, maybe for 3 years, can I check my bone mineral density? If it's improved, I may have protection even past me stopping it at that 3-year point. And there are other medications your doctor might talk to you about. There's calcitonin, there's hormone replacement therapy with bioidentical natural hormones, and then there's certain vitamins and minerals that I'll talk about. So there's other options if you can't tolerate this medication. So that goes on to our natural treatments, which is osteoporosis is preventable, and it has a lot to do with diet. So it's not just about calcium. We want to talk about other minerals, hormones, and lifestyle. Here's my generic handout for every single talk that I give, especially the first 2 pointers. Eating 8 servings of vegetables a day, it seems like a lot, but it's doable. If you can't do it every single day, at least try the 80-20 rule. Try to get it as often as you can. You can see, research shows that vegetarian diets are associated with lower risks of osteoporosis. And a lot of it has to do with that. Unfortunately, animal protein does increase the risk of calcium and mineral depletion. So eat lots of vegetables. Try to eat, no more than 2 servings of fruit. The reason I say that, fruit has a lot of sugar, so we don't want to affect someone's blood sugars, but most of the nutrients are in vegetables, so you can still get that through fruit, but if you're trying to get nutrient density foods, vegetables are the best. Low animal fat, low animal protein, limiting refined carbohydrates, limiting alcohol and caffeine. So what vegetables are we talking about? Broccoli, collard greens, kale, bok choy, those are probably one of the highest nutrient-dense foods. Foods that are highest in calcium along with those vegetables are, if you do eat meat, I think salmon and sardines, especially with the bones that are cooked, are the best sources. And then dairy is still a good source, but don't just rely on dairy. Your vegetables can go a lot further. So dark leafy greens again. If you look at numbers, just 3.5 ounces of kale gives you 249 milligrams of calcium. And same thing with parsley, that's not too far, 203 milligrams. Broccoli and even lettuce, surprisingly, is high. So eat as much as these nutrients as you can. We'll talk about where your diet, like how many milligrams you should get through diet and also through supplements coming up. Okay, so here's foods that cause calcium loss. The reason I emphasize that is a lot of times we focus on what should I eat, but what if you eat all this good stuff and then you cause damage by eating bad stuff? So first we always say remove the obstacle to cure. Let's get rid of the bad stuff and then your body can actually maybe absorb better, right? So high phosphate intake. What is that word? Carbonated drinks. It's not just Coke, Pepsi, whatever else carbonated. It's actually carbonated water as well. And I say that because a lot of people are like, oh, I just drink, like a water kind of, like a Perrier, that sort of thing. Once in a while, enjoy it, but just don't drink it all the time because it's still it's the phosphates that cause the bubbling. So you don't want to rely too much on that. High protein diet is another risk factor. So you can see in a study, they had people who raised their protein intake from 47 grams to 142 grams, and it doubled their excretion of calcium. So 142 is a fairly high protein diet. The average person needs about maybe 40 to 70 grams of protein unless you're weightlifting and you're quite athletic. But this is, to me, a high protein diet. So rely on more like a 60 plus minus 20, that sort of thing. So you can see high intake of animal protein specifically, not necessarily just plant protein, correlated with that increased fracture, and they saw that measured in the forearm. Part of the reason with that is animal protein is also high in phosphorus, which is the same as that phosphate intake through carbonated drinks. The other one is that animal foods can sometimes get in the way of too much methionine. Remember we talked about that homocysteine? Methionine is an amino acid, so the more you eat that, the more likely you could convert to homocysteine. So there are all these connections. Okay, so here's that 300 magic number I promised. So other causes of calcium loss. We've got high sugar intake that you want to limit. Limit caffeine to less than, does that look like? Okay, yeah. Less than 300 milligrams of coffee a day. So that's about 18 ounces of brewed coffee. It's 300 milligrams of caffeine. Anything more than that, accelerated loss of bone at the spine. And then, don't forget soda too. That there's also caffeine in that. Okay, so I just want to talk now about calcium not being the only thing to focus on with osteoporosis and some of the bad media reports that we've read about calcium. So if you see in here, first of all, calcium is important. We know that. We just want to break some of the myth. So calcium is broken down by stomach acid before it's absorbed in the intestine. Does that sound familiar? We talked about antacids and how calcium absorption is affected. So the reason I mention that is there are two forms of calcium I always look at. Have you guys heard of calcium carbonate and calcium citrate? Believe it or not, calcium citrate is the best form, but carbonate isn't as bad as we think. The time where it's bad is when our stomach acid is the lowest, because our stomach acid is needed to convert the carbonate into more absorbed form, whereas the citrate doesn't necessarily need the acid in the stomach. So the take-home message is those who have a low stomach acid, especially who are taking antacids like Prevacid, they're better off purchasing a supplement with calcium citrate in it. The elderly, as we get older, our stomach acid naturally decreases, especially those who have gastritis. They have lower acid in their stomach. So you might want to start thinking more about taking calcium citrate in those cases. The rest of the population, carbonate isn't as bad as we thought. So I just want to kind of distinguish what these two are coming from. Okay, so talking about dosages. So in terms of how much we need, it varies by age. So during our developmental age, it starts to increase. So from age 1 to 3, it's 700. Age 4 to 8 is 1,000. And then really during puberty, it starts to peak at its highest, 1,300 milligrams of calcium a day. And then from age 19 to 70 and onwards, it's 1,000. I don't know why it stops there. And onwards is 1,000. But sometimes we do recommend women who kind of are reaching that menopausal age to kind of increase it maybe to 1,200. So different groups say different things. This one was Institute of Medicine. I think the World Health Organization might have slightly different, but the ballpoint's about 1,000 to 1,200 milligrams of calcium. I usually recommend to get at least half of it through food. And then you could get the other half through diet. So even people with osteoporosis, I may not, recommend more than 600 milligrams of calcium. That way we're sticking to, not going above that risk of, aortic calcifications and all the possible, kidney stones and all that. So I'll talk about that part coming up. So you could see the reason that's important is calcium helps to build strong bones, including teeth. It's also important for your heart. It helps your heart rhythm and contractility. So it's not just about bones. A lot of people say, well, why can't I just measure my calcium through blood? The reason being is your heart, believe it or not, we know that. Your heart is what keeps you alive. So your body will borrow from anything, including your bone, to keep your heart beating. So your levels of calcium are almost always fixed. It's hard to diagnose osteoporosis through blood. We have to look at bone mineral density for that reason. I mentioned some food sources, and okay, so we'll keep going here. Let's see. So here are the studies I talked about. So there was a study that talked about calcium increasing the risk of cardiovascular disease, stroke, and myocardial infarction. That's scary. We want to pay attention to the study. When we look deeper, what we saw that this study only had calcium. There were no other minerals. There was no magnesium, no boron, no vitamin D. It was a calcium-only study. And then the dosage of the calcium was really high. No one was taking less than 500 milligrams of calcium. And no one suffered these side effects when they were taking that dose. That's why I always stay to that 600 or less. I don't want to overdose it too high. The other study was calcium increasing the risk of kidney stones. Again, that study was a high dose calcium, and there was no magnesium in there. It was a calcium only study. If anything, magnesium reduces the risk of kidney stones. So when you put them together, it not only directs calcium to get to the bone and absorb better, but it will, if anything, magnesium protects the kidneys. So those were the probably two most alarming studies. The other thing is that the form of the calcium mattered, so the calcium citrate was less likely to cause kidney stones than calcium carbonate. So take-home message is we don't want to dose more than, I always say 500 to 600. We don't want to go higher than that. We don't want it to be calcium only. We want to pair it with magnesium, boron. I'll mention all the other ones. And then if you're worried about kidney stones, magnesium citrate actually helps to prevent it. So if you need to take calcium, definitely take it with magnesium. Okay, I pretty much summarized it, but here's the combination. Magnesium, vitamin D, boron, manganese, phosphorus, and vitamin K. You want to combine that. Calcium citrate overall is the better form. As I mentioned, some studies suggest calcium carbonate needing stomach acid. And the body can only absorb 500 to 600 milligrams of calcium at a time. So even if we were to take 1,000, you don't want to take it all at once. You do want to break it down. I even say you could break down this 500 to 600 into divided doses, maybe like 300 in the morning, 300 at night. Conclusion, best to obtain the rest of your requirements through diet. Okay. Here's another one, calcium and safety. Up to 1,500 milligrams a day doesn't appear to cause kidney stones, but again, it's best to be taken in divided doses. So some of these studies were like really high doses of calcium, but again, I would stick to that 500 to 600 mark. How are we doing for time? Good. So vitamin D, in terms of what it does, it stimulates osteoblasts. They're the ones that form bone. So that's why vitamin D is important. It helps calcium get absorbed. And then it also helps cell proliferation and protects your heart. And this is part of the reason I mentioned I'm always in the sun and my levels are low. It may have to do with certain skin pigments and the way it absorbs. So the body first absorbs vitamin D through the sun, then the liver and the kidney convert it and it becomes vitamin D. So supplementing through vitamin D bypasses all these steps. That's why some people need to take a supplementation to raise their levels. If you take it through food, salmon, sardines, fish oil has some vitamin D. And then there's two forms of vitamin D. There's vitamin D2, which is what your doctor writes in terms of the pharmaceutical. And then there's vitamin D3, which is the natural form. It is made from the linolin, it's from the skin of the sheep. Some consider it to be vegetarian because it's not from the flesh of the animal, but if you're vegan, it's kind of pushing it. So some people do elect to take the prescriptive dose, which is D2, but if you're vegetarian, you might want to just stick to D3 because again, it's not harming the animal. It's just using the kind of the what's it called, layer of the sheep that's going to get cut anyway or shaved. Okay, so this is the typical dose of the minimum dose of vitamin D that I would recommend. I think the best level would be around 50 to 60. But a lot of times what the studies show is that if you take 400 IUs of vitamin D, it almost has no impact on bone mineral density. If you take about 800, maybe it keeps your levels steady. But if you want to build bone or if you want to raise your levels of vitamin D, you need to go higher than that. So you could ask your doctor for the right dose for you and then check your vitamin D every 3 months to make sure you're getting to that point. Once you get there, then you could get to the maintenance dose. Okay, and then another common deficiency is magnesium. So it's an important one for calcium. Calcium and magnesium go hand in hand, so you definitely want to take them together. And the other ones to look at is manganese, zinc, boron, copper, B6. So remember that folic acid and B6? Like a good calcium supplement will have those two. So if you say, what does that have to do with bone? Now you know it's through the homocysteine pathway. You want to reduce that likelihood of it happening. Vitamin C, vitamin K. Sometimes they add iproflavone, red clover, or black cohosh. Those are herbs that actually have like a phytoestrogen quality. So we know that as we age, as we reach menopause, there is that correlation. So this kind of has like that protective effect through supporting estrogen. Flavonoids have been shown to support collagen formation, so that's why sometimes they add that. Here's phytoestrogen, so they add things like black cohosh, as I mentioned, fennel and dong quai. And then fish oil has an anti-inflammatory effect. We always want to reduce inflammation whenever it comes to any health condition. For the sake of time, I'm going to skip some of these. Zinc is important, B6 is important, I talked about this. Vitamin C is important for cartilage formation, synthesis of cartilage, tendon, ligaments, basically the framework of our body. We talked about vitamin K being really important. Iproflavone, as I mentioned, it kind of has like a soy phytoestrogenic effect. So sometimes you see iproflavone as a treatment. And then again, talking about anti-inflammatory, so you could use curcumin, which is turmeric, and then or another blend of boswellia, which is an anti-inflammatory herb. We're almost done. I just want to go over the most important, one of the most important parts, which is exercise, and then we'll have about 20 minutes for question and answer. The reason I wanted to skip through this is we definitely want to use exercise as a therapeutic treatment of osteoporosis and a prevention. But again, it's back to first do no harm. There's certain movements that may actually be a risk for people who have osteoporosis. So I just want to bring that to your attention. So we know that people who exercise, especially when they do weight bearing, it puts pressure on the bones and it helps to build bone. So weight bearing is really important. So is resistance. The other component is balance and coordination, preventing fall formation, right? And then or falls. Improved muscle strength and flexibility, increasing endurance through our daily living and posture. So there are two types in terms of building bone. We've got the weight-bearing exercises, is things that work against gravity. Remember that book, Sitting Heels, Moving Heels? You want to work against gravity. So it's things like walking, jogging, climbing stairs. Unfortunately, swimming is a good form of exercise, but it doesn't count as weight-bearing. So you want to do something that's kind of has an impact. Resistive exercises are more weight, so you strengthen your muscles. In terms of frequency, what's been helpful is doing it about 2 to 3 times a week, each time for about half an hour. And then the different muscles that are worked, you want to do 3 sets, about 8 to 10 repetitions. And there was a really good study. It said that after 22 months of doing this exercise, it increased the bone mineral density of the lumbar spine by about 6%. And that's huge. It says like only 6%. It's a lot, because imagine how many people can get stronger and not fall and have their quality of life be affected, right? So by 6%, but this is the sweet part of it. After 13 months of stopping or reducing the activity, it didn't just go back to nothing. Like 13 months later, they were still 1.1% above where they were before. So you could still kind of like enjoy the ride months and months later from doing the exercise. So the most common sites of fractures to remember are your vertebral body, your hip, and your wrist. So we want to focus on strengthening those, but not putting any extra impact on it. So remember that. In terms of that, there's certain movements like flexion that puts a lot of pressure on your spine. So when you bend down, a lot of force goes on your spine. So any exercises where you're flexing, if you have osteoporosis or osteopenia, definitely avoid them. You want to do a lot of extension exercises that strengthen and stretch your back muscles. So these would be things like flexion means touching your toes, doing sit-ups. You basically want to do the opposite of that, because remember kyphosis, that was that like forward bend. It promotes that. You don't want that to happen. So you can see 16% of the fractions happened in those that there may be a risk with extension, but compared to 89% fracture with those who did a flexion. So avoid excessive rotation too. Too much twisting can put pressure on our spine. And then obviously too heavy of weights. We don't want to do too much too soon. So here's a little pop quiz. We've got, hopefully everyone can see this. I know it's a little bit too low. We've got figure 5, 6, 7, and 8. The question is, which of these movements must be avoided with osteoporosis? 5 is 1. Okay, what about 6? Is that okay? 6 is okay. What about 7? No. Yeah, especially like overdoing it, right? Maybe a little bit might be okay. What about rotation? No. So these ones, maybe the exaggerated forms I would avoid. A little bit of it is okay. I think a good yoga instructor might be able to support you through proper balance and strength so that you don't overextend. But in general, the best form is to do more extension exercises and flexion.
So the second one is okay?
This figure 6 is good. Yeah. You want to do more of that, and definitely not more of 5. No 5. No flexion. Okay, so here's a good example of good extension. So you can see, this kind of extension is okay. It actually stretches out your spine. This person's probably balancing themselves on this foot. So this is yoga. Same thing with here. They're definitely balancing. They're not over pressuring anything on their body. This is a little advanced, but if you can do that, you're in good shape. You can balance yourself. So I think yoga is one of the best forms of exercise because it promotes flexibility, it promotes balance, it promotes strength. And I think it's really good for kind of a calming, kind of anti-stress. So it just has so many holistic benefits. Other examples or benefits of extension is that it strengthens your back muscles. If your muscles are strong, it could protect your spine, right? So you definitely want to do that. And okay, let's see. So that is it. So balance is also important because it prevents falls, prevents fractures. A good example of something you could do to test your balance is you could stand on one foot and then open and close your eyes, and then alternate foots and do that, and just see whether you can really rely on your balance to keep you. I think yoga is actually another good way of testing your balance, but this is a good test. And then jumping up and down with one foot, it really kind of, double checks your balance. And then 5 minutes of this can significantly reduce your rates of falls. This is another great study you could see in women 75 and or older. Muscle strengthening and balance exercises reduce the risk of falls by 75%. And this is from Journal of American Geriatric Society. This is a really good article. So exercise is huge. For those who are sitting all day in a slouched position, be warned, it puts a lot of pressure on your spine. There are a lot of people that I see that are forced to get an x-ray for whatever reason. They were in an auto accident, or they just end up getting an x-ray, maybe a chest x-ray, and it ends up that they get an x-ray of their spine. And then it says that they have like some kind of like a decreased space of their disc. And they're like, how did this happen? I've had no injuries. Well, if you're sitting all day doing this, it really compacts your cervical spine. So definitely sit upright as much as you can. Focus on your posture and try to get up as much as you can. So definitely make sure you follow your posture and it's aligned. So again, going back to avoiding high impact exercises if you do have weak bones. You just want to do more gradual exercises. Anything that there's a risk of falling, you want to be careful. No flexion or rotation. And then definitely get someone to supervise, especially if you're starting a new exercise program. Last thing you want to do is go hardcore and get discouraged or get injured. Last but not least, risk reduction. Back to first, do no harm. Assessing if someone has osteoporosis, making sure their home is safe. They're not going to be falling and tripping in certain places. There's no drugs where they're getting dizzy and falling. Checking nutrition status, checking vision, making sure that's not going to cause falls. Looking at medications that may be sedating. Again, that might be like affecting their alertness and then maybe falling. There's a whole lecture I can talk about on this for stress. Stress actually increases your body's levels of cortisol, which is your body's levels of steroids. So steroids can actually have a negative effect on your physiology. It wouldn't surprise me that those who are in a more stressful situation can have accelerated aging, which osteoporosis is a part of. So stress management is really important. And then sedentary lifestyle. So with that, we have about 20 minutes as promised for question and answer. Yes. You know what we'll do? Just for your privacy, maybe we'll just shut down for Q&A. Yeah. And then if you guys